Great, great, great. Well, welcome everyone. We're so excited to host this webinar for you, our beautiful community. My name is Tasing Parker. I am the Executive Director of the Bayview Hunters Point YMCA, and I'm joined by some amazing people. I'm going to let Dr. Mo introduce herself and then want to introduce our panelists for today.
Thank you all. Welcome everyone. This is Monique Lassar from Rafiki Coalition for Health and Wellness. Super excited to welcome you to the Village Conversation and really to have an opportunity to ask your Black doctors and feel very fortunate to have these two amazing people with us. And of course, my amazing partner here, Director Parker, who is resplendent in purple. Thank you and welcome everyone. There's a great question I'm seeing in the chat. Please make sure to put it in the actual Q&A. Thank you.
Thank you so much. So again, welcome everyone. I'm so excited to bring you the community, our wonderful community, information about the COVID-19 vaccine. We are joined by two amazing individuals, none other than Dr. Ayana Bennett, who is the Director for the Office of Health Equity with the San Francisco Department of Public Health, as well as Dr. Malcolm John, who is the Professor of Medicine for UCSF. Welcome, Dr. Bennett and Dr. John. Thank you so much for being here today.
My pleasure.
Thank you. Well, we're going to jump right in. As Dr. Mo mentioned, if you have questions that you would like to ask, please do go ahead and put that in the chat, in the Q&A section at the bottom of your screen. Dr. John will be presenting first, and then Dr. Bennett will come immediately after him, and we're going to give an opportunity for some questions to be asked as well. We know that there is a lot of information that's out there on vaccines. So much is going on, and folks really want to get the truth and the real about the COVID-19 vaccine. And so we're excited to have Dr. Bennett and Dr. John joining us today, and we're going to just go ahead and jump right in. So Dr. John, take it away.
Hey, thank you so much, and thank you for having me. So grateful for the opportunity to share with the community and to be helpful if I can be. And I will just say that up front, the reason I do these talks is not to convince people one way or the other. If you ask me, I think everybody should get vaccinated. So I'll be upfront. And there are reasons for that, and we can talk a little bit about that. But I think the most important thing for me is for people to make decisions from positions of strength and knowledge, and not from fear. And that's really what it's all about, right? That you have the information to make the decision that is best for you and your family, your loved ones, your community. And I think that that's really what drives me. And so I'm really happy to have a chance to do that. Really sophisticated questions already. So it's going to be a tough crowd tonight, a good one. So I'm going to jump right in. Can I share my slides now? Yeah. Okay, so I'm going to just do a quick set of slides. We're going to leave lots of time for questions. So this is COVID vaccine, and I'm representing myself as a Black male in America, but also a Black physician at UCSF and the Black Health Initiative, which we launched last year to address COVID-related disparities and other disparities in the community by helping UCSF just be a better partner with the community. So I just want to briefly remind folks that when we talk about COVID-19 at the bottom here, that's really the disease or syndrome. It stands for coronavirus disease from SARS-CoV-2. And so COVID-19 is the year. SARS-CoV-2, which is right above here, is the actual virus. It means the coronavirus that is causing COVID-19. And how do you get that name? It's not really important. Back in 2003, we had an epidemic, not a global pandemic, from this lung disease called severe acute respiratory syndrome, or SARS for short. It was caused by coronavirus, and that's how you get SARS-CoV. And this is the second virus that is causing a similar syndrome, and that's why the number 2. So SARS-CoV-2, severe acute respiratory syndrome, coronavirus 2, causing COVID-19, coronavirus disease 2019. And so, as most of you know, you can get pretty much any type of symptom from your head to your toe, mainly flu-like symptoms that we're all familiar with 2 to 14 days after exposure. That's why We quarantine after exposure. And the most significant one, or the one that clearly is linked most, is this sort of loss of taste or smell. And that's, if you have that, obviously, you're more likely to have COVID. And then the next slide, and I will slow down after this, is really to just show the effects of COVID-19 on the human body. And what do you see? It's all over. It's not just the lungs, right? You get a lot of disease in the first week, it's mainly lungs, but it's that second week when your body is going crazy, producing all these reactions. It affects all different parts of the body, and that's really what causes people to die from this disease. And what is not spoken about so much, but is getting more attention now, is if you survive COVID-19, many people are living with chronic symptoms, mainly confusion, brain fog, chronic fatigue, damage to their lungs and to their hearts. Those are the more common ones. Okay? So let's just get to the vaccines itself. There are two approved right now, Pfizer and Moderna. They're very similar. People often ask me what's different about them. For all intents and purposes, they're the same in terms of what they are. We'll go through a little bit of differences. They're both highly effective, 95% protective in preventing serious and symptomatic disease, really. And to give some perspective, we would have been happy or satisfied at 50%, happy at 70%. We're ecstatic at 95%. Measles vaccine has an efficacy of 90%. The flu vaccine, which prevents epidemics and pandemics, has a protection rate of 40 to 60%. So that gives you a sense of what we're talking about. And it's 2 shots, as you know, not 1. And here it is side by side. Pfizer on the left, Moderna on the right. They're the only 2 FDA approved in the United States. You'll hear about other stuff in other countries, but these are the 2 that is available. Pfizer, 16 and above, Moderna, 18 and above. Pfizer, the 2 shots are separated by 21 days, Moderna by 28 days. Pfizer is the one that has to be really deeply frozen, or you have to use it the same day. And so usually those are associated with larger health institutions that have that capability. Moderna also in those type of institutions or facilities, but the Moderna can be frozen in our regular type freezers. And so that's a little bit easier to handle. People will, I'll just say here, people may have heard about Johnson & Johnson. They have applied for approval. They are not approved. The big thing was it doesn't need to be frozen, and it was a single shot. It's not the same efficacy, and we don't know how it will be used. We can talk more if people are interested. This is the one slide I do want to take a breath and just have people kind of pay attention here, okay? Because this is how mRNA vaccines work, starting from left to right, 4 panels, okay? So we're gonna start in the first panel on the far left. This is the coronavirus with the red spike proteins on it, which are the typical proteins that give it its name. They look like a crown in certain cuts or slices of images. And the spike proteins is how it attaches to our cells in our lungs and other tissues in our body. So it's an essential, really important for attachment. And inside the coronavirus is something called RNA, specifically messenger or mRNA, that gives the instructions on how to make a coronavirus. So I am going to take a little bit of biology time here and explain what mRNA is, okay? And some of you may have heard me say this before, but I think we all know what DNA is, okay? DNA is the code of life. You've heard that term before, the book of life. It has all the instructions of how to make a human being head to toe, inside and out. It's so important, it has to stay in the central library of your cells. And that's the nucleus or the center of the cell. The name is not important. What you need to know, the code of life, book of life, too valuable to leave the library, stays in the central library. But you have to get instructions to the factory workers every day in terms of what to make. So you go old school, okay? Pen to paper. You go to page 27, how to make, I don't know, a liver cell today. Page 27, you write down the instructions from page 27, you take it to the factory workers and say, here it is. This is what we're gonna make today. That piece of paper is mRNA. It's the copy on a piece of paper that has the instructions for the day. And because of that, it goes hand to hand to all the workers so we can see it. It's a flimsy piece of paper. By the end of the day, it's gone, it's torn up. And that's a good thing because you don't want too many liver cells, okay? So mRNA in the humans lasts around 10 hours to about 3 or 4 days. And that's what happens with the vaccine when you get it. People have asked, how long is it in my body? That's about the time, okay? So what is in the vaccine? Moving from the first panel on the left, they took out a small piece of mRNA with instructions for this very important spike protein, and they put it in 4 oils, and 4 salts to protect it. It's a flimsy piece of paper. It needs protection to get into your cells. So 4 oils, 4 salts, no fetal cells, no nothing, okay? And that's what they cover it with, put it in a syringe, put it in your arms. Panel 3, it gets to the cells. The mRNA, the flimsy piece of paper with the instructions for the spike protein, gets into the cell. The cell makes a spike protein, puts it on its surface in bits and pieces or full form. And suddenly the body, which has nice cops and nice military, not like the ones we've been dealing with, okay? So really nice police coming around, they check your house, they wanna make sure everything is looking good. They see this spike protein and say, wait a minute, alert, this is not supposed to be here. We have to get prepared for an invasion, okay? And this last panel shows it gets prepared by making these things called T cells and antibodies. So when you're exposed, the next time you're exposed to the real virus, it'll stop the invasion. And that's it. I hope that's clear enough. Happy to keep answering any questions. So you get that vaccine. They studied it in 43,000 people in Pfizer, 30,000 in Moderna. The thing I want you to see, 10% were African Americans or Blacks. We represent about 14% of the population, 13 and 20 of Hispanic, Latinx, Latin Americans, and Asians and others were represented. Importantly, lots of folks who are older and at higher risk as well. So this vaccine is effective in people who are over 65 with the highest risk. It's equally effective in men and women. Men die more of COVID than women. It's effective in all age groups from 16 and above in Pfizer, 18 and above in Moderna, and all ethnic groups, as I showed you. And importantly, people who are at risk, no matter what their age, from obesity, high blood pressure, diabetes, HIV, things that are common in the community and certainly in our communities as well. A lot of folks ask about side effects. Yes, the majority of people, I'm talking about 80 to 90% of people, will have some side effect, whether it's a sore arm like I got when I had the vaccine. It lasted for about 1 to 4 days, or it could be fatigue, headache, fevers, etc. It happens mainly after the second shot. My wife got Moderna. She had nothing after the first shot. After the second shot, she got it on a Saturday evening, Sunday. She was flu-like in bed, having, just not feeling great, drinking hot fluids, whatever. Went to work fine enough on Monday, and Tuesday was 100%. I had no problems after my second shot. I got Pfizer. There are rare cases of an allergic reaction. That's about 10 or 11 cases per million. So about 1 in 100,000. To give some perspective, in a car accident, your risk of dying is 10 times that, 10 in 100,000 or so. And it's treatable. That's why you have to stay for 15 to 30 minutes after you get the vaccine. So you're in the right setting if it happens. Get some steroids and you're good to go. But what do we not know? And I saw some questions in the chat. We don't know if it prevents infection if you get the vaccine, meaning you could have some set up in your nose and you could still spread it. We don't know. Some vaccines aren't very good at getting to the nasal passages. They are studying that. And so that's one question. We hope and anticipate that it will be okay, but we have to prove that. There's some early data from AstraZeneca in England that it might prevent transmission. And that's that second question. Are there rare immediate side effects? Well, we are monitoring. After vaccines, you do get monitored. And there was a case of a doctor in Florida with this bleeding thing that happened, and people were wondering. Again, one case out of 40 million vaccines here in the United States, 177 across the world. I'll take those odds. And then, is it okay with pregnancy? Well, we don't know specifically because not enough pregnant women or people with autoimmune disease like lupus, but people have been getting it. It's not a contraindication. Talk to your doctors. Our facility is encouraging pregnancy. AstraZeneca in England is studying in kids. Long-term side effects, really important question that I already saw in the chat. Really, most vaccine side effects occur in the first 6 to 8 weeks, maybe out to 6 months. There's no vaccine that has long-term unknown side effects that show up years later. That we don't have that. People were worried about measles, mumps, rubella in the past, and encephalitis and all this sort of stuff. It doesn't happen. You get your response in the first 6 to 8 weeks, and we have millions of people now who meet that criteria. How long will the protection last? Great question. We don't know. We anticipate some form of booster in the future is likely to be required, especially now that we have variants. I'm going to skip this slide. We've already talked about the efficacy and what's not going to change: social distancing, wearing a mask, washing your hands, and sheltering in place as needed. And then I'm going to end with two thoughts. One is about the vaccine, weighing whether or not it's a good option for you. And I will say that 5-6 months ago, my wife and I, my wife's a physician as well, neither one of us wanted to get the vaccine. It was Donald Trump era. It was warp speed, whatever that means, sloppy speed. I don't know what that means. And couldn't even trust science, so CDC wasn't really helpful. So by the time December came around, she was like, you go first. By the time December came around, she got picked first and she was like, aha, I beat you. And so what really changed? Well, we did our homework. These mRNA, this technology has been studied for decades, since the 1990s. And since 2003, when they had that first SARS outbreak, people have been looking for ways to prepare for the next pandemic. And so they've been using these models, these mRNA and other models, to develop vaccines. They've used mRNA technology for treatment of cancers, skin cancer, published in our journals. They've used it in heart disease. They've used it for flu and herpes viruses and shown some benefit. But the important point is they showed safety in humans. Of course, not in the tens of thousands and now millions like we have vaccinated for COVID, but it's been there. And this whole warp speed thing was Trump trying to take credit for the work. And really, it's sort of like you had a business, a bakery with a special pastry that your neighborhood knew about and really enjoyed. And one day, a successful business person came in, loved it, and said, let's go into business together. Here's $1 billion. And suddenly your shop's all over the place. And everyone says you're an overnight success. And really, you're like, please, I've been hustling for 15 years doing this. So keep that in mind. And then the last thing I will say is me getting the shot here was not so scary. The last thing I'll say real quick, and I'll pass it off to Dr. Ayana Bennett, is the example that I share with folks about Viagra. And it's kind of a funny thing, but it's really an instructive thing. So I'm a physician. Viagra came out. Just about every male patient, every male family member asked me for Viagra. Okay? They just wanted it. How many of them asked me about the studies and how many safety profile and long-term side effects? Zero. Okay? I promise you, zero. And people die of Viagra if you have heart disease and you're taking nitrates, but zero. And the lesson here is two things. The perceived benefit from Viagra was so familiar and high, right? We all know about sex and intimacy. So the perceived benefit was so high that they trusted the system to have done its due diligence, like it has done with these vaccines. Okay. And so I think it's really important for us to think about what's the value of vaccination for us, our families. If we take care of aunties or grannies, if we have grandchildren we want to hug, if we have birthdays, to have birthday parties again, those are really things to think about. And then the other thing was a lot of people were like, my buddy got it, worked for him, I want it. And Viagra doesn't work for everybody, but people knew others who used it and vouched for it. So instead of spending too much time on the internet looking for every weird thing, ask the people you know who got vaccinated. Look at them. Why did they make the decision? How did they do? And so on. And I think that that's really instructive. So with that, I thank you for your time and pass it on to Dr. Bennett. Really appreciate it.
Thank you, Malcolm John, for covering so much of the science. So I am leaving almost all of it out, everybody. I am not going to go over it again. And Malcolm, I left you all the questions that I thought you were already answering in your talk to say I answered in the Q&A. So hello, everybody. I am very glad to be here. I am, like Malcolm, I am banging the drum. Do what you want, but you will have heard the drum. And if you get in line, okay. If you don't, okay. But we are doing the drum. So let me share with you some slides. I'm, for the most part, going to be talking about really the effort to get the vaccine to you and whether or not you will know enough in order to make your decision and how to go about getting it. So really the more practical stuff. Can you hold on a second? Oops. Yeah, can we see my screen? Yep. Okay. So I'm going to do some practical stuff for you, and then we will go over some questions. So I'm going to say the role of the vaccines in the pandemic. Dr. John went over kind of how they work. I'm going to talk a little bit differently than that, give you a little bit of history that I think you already know, but I want to acknowledge, talk about the vaccine distribution process, and then some of the challenges and what we've managed to do despite those. So the vaccine is a critical tool to slow the spread of COVID-19. So I would like movies back, and I would like to see my mother, who is getting older and older. So I have goals. All of you have goals. This is probably the most important tool. There are lots of more important behaviors and things you can do, but this is the most important tool out in the world in order to get us those things. So most of you are going to get it from your own insurance provider. If you have a job and you have health insurance, they have been given vaccine to give to the people in their network. That is especially true for the larger providers. Some people will get it from the county. Our job at the county is to make sure that the people who can't get it in other ways get it, and that we're doing it in a way that really maximizes the impact on the virus. So we're looking for where is it most effective, which means where is there a lot of infection. So the general population is likely not going to get vaccinated until later in 2021. That means if there's nothing high risk about you, you probably are going to wait. Your job's not high risk, your health condition, your age. So the vaccine's not recommended for children because they haven't tested it in children yet, but those studies are being ramped up now. I expect that they will occur in the next few months and over the summer. And the expectation is that we may see child approved vaccines by the fall. Fingers crossed. So the vaccine's free. The government's bought all of the doses, millions and millions and hundreds of millions of them. The administration fee is covered by insurance, so it shouldn't cost you anything. And even after being vaccinated, as Dr. John said, you do need to wear your mask, physical distance, wash your hands, and he explained a little bit why. So this is why we want people vaccinated. So right now we have 121,000 San Franciscans, and that's, we have far more people in the city because lots of people work here in healthcare who do not live here. So it's more like 200 something thousand of those people, but 121,000 people in San Francisco have gotten at least one dose. 35,000 have gotten both doses. And so those are still largely healthcare workers, emergency services, people who live in nursing homes. We're at about a pace of 5,000 a day as of about last week. We want to get to about 80,000 people vaccinated. That would be about 9% of the city residents. We're at about 5% now. We think that at 9%, if you add that 9% to the number of people who've already been infected and who we think have some immunity, that puts us at enough immune people, not for herd immunity, but to start to see the curve go down faster. The milestone would be getting a sustained rate of 10,000 vaccines a day. That'll get us to vaccinating the 600,000 or so we need to vaccinate in the city. And the target condition at the end is to get over 900,000 people in San Francisco who are or working in San Francisco vaccinated, and to do that equitably so that people who are high risk and in communities that have less access have gotten it. And all of that is going to be dependent on vaccine supply and data reporting. Do we know where the vaccine is and who's gotten it? And are we going to finally get enough from the government to give you? So I'm going to pause for a minute on facts and talk about not facts necessarily. So we have heard a lot about vaccine hesitancy. I refer to it as historical awareness when I'm talking about this gentleman over here who has in his people a history that warrants some questions and some concern. And vaccine hesitancy really, I think, belongs in this other group where people have heard a lot about stuff. They read a bunch on the internet. They have concerns, but they are probably not based on history per se. So both of those people are in the group of people who have questions about vaccines. The group that I think most of our community belong to are people who have questions that can be answered. It's not a conspiracy theory. It's, I have legit questions. And if you can answer them, then I might get on board. So that's what I'm going to try to do, is answer some of those questions. So we know why we have those questions. So there's been deception, exploitation, giving people something for your own purposes, not for their own good. Denial of service. Most of the time it's that we can't get the thing, not that they gave it to us and they shouldn't have. And coercion, where people don't have a choice. So all of these episodes, polio, HIV, we all know syphilis and Tuskegee, the 1918 flu, there have been lots and lots of episodes, and many more than that, where something in that list has happened and people have told their friends and family. It has gone down through the generations. And so people know something could be wrong. But I just want to be clear that that something has been deception, exploitation, denial of service, and coercion. And so when you know that that's what's happened and it's not just a vague badness, then you know what you can ask. So what I'm suggesting people do is test for trustworthiness. So the system has not always been trustworthy. It's not that we don't trust, it's that trust has not been earned. Well, how do you test whether you can trust something? So ask, are you having any of those things happen? Are you getting equal information as everybody else, which suggests that you are not being deceived? So you are getting the same commercials and pamphlets as the rest of the city is getting. In fact, the rest of the planet. So these same vaccines are being given all over the world. Are you getting the same risk as everybody else? People are worried about being guinea pigs. The guinea pig phase is long past. We are in the millions of doses now, and that's in the millions just in the US, let alone in all of Europe, England, Scotland, the rest of the planet. So we are past that phase. You are maybe, if you're lucky, in the early group, but you are not in a group where we have no idea what's going to happen and we're just testing it out. There are far more middle-class white people who have gotten this vaccine than any other group. And so we are not being tested on. We are trying to get our bit of just amount that we should do. Equal access, are you getting the same access? Most of the time, what happens to communities of color is not that they get something they shouldn't, is that they don't get the thing that they should. In this case, we are being asked by the government, more so now, and we are trying very publicly and actively to make sure that the communities who do get it first and most are the ones where the virus is the most, and that is in our Black and brown communities in this city. Are you getting equal options? So are you being coerced? Do you have the option to say no? Are you being bullied? Is there something you can't get if you don't do this? At the moment, none of that is happening as far as I know. And if it is, get out of that line and get in a different one, because right now you have the option to do it, to not do it, to go up there, to say no. Please don't do that because we have to waste your dose, but you do have that option. So you're not being coerced, you're getting the information, you're not at higher risk, and you're getting access. So I would say in this case, you have enough information to think that this is maybe more trustworthy than lots of other things that happen when it's just you and your doctor in a room and you don't know what else is happening in the world. This is happening to everyone at once. So the state and federal government are deciding how this is going to be given. So the prioritization is coming out of the federal government, being translated by the state. So the city, no one in the city decides who gets vaccinated first, not really. We're required to follow the state and national recommendations in order to get our free vaccine. And DPH is responsible for allocating and administering just the portion that is meant for the public that DPH takes care of. So the rest of the vaccine is being given to Kaiser or given to Walgreens. We are not in possession of all of it and allowed to keep all of it. And that decision about who gets how much is not ours. How does the vaccine get into the city? So we have the pathway for vaccine is the feds purchase it. They divide it between the states. There are federal programs for pharmacies, so they get theirs directly from the federal government, not going through the state. And then the federal government, of course, gives it to the VA. So the local allocation comes through the state, and that means not from the part that's not coming from pharmacies. The state gives it to large healthcare organizations, and they call those multi-county entities. And you can imagine if you're not big enough to be in more than one county, you're not getting it. But that is all your Kaisers, your Sutters, all of the places you know usually operate in more than one county. So most of our local systems have vaccine, and then the local health department. So they're meant to vaccinate two different groups. The health agencies are meant to vaccinate to their clients, and they can vaccinate to all comers. And that is what we're trying to do at some of our sites. The county is meant to vaccinate people who have barriers, who can't otherwise get it from their doctor, all of those things, and the people we're already responsible for. Pharmacies have a contract directly with the government to vaccinate long-term care residents. So those are people in nursing homes, and we're expanding that a bit to some of the other residential care facilities. And the VA, of course, takes care of the VA. Most facilities get theirs directly from the government or the state, and some of it comes through the city. We are in a phased rollout. So they do not have enough vaccine to just vaccinate everybody. It is coming slowly because we are in competition or in cooperation with virtually every other country on the planet for the same small number of vaccines. So we are a big, rich country, so we have a lot, certainly more than many countries do, but not nearly enough to just vaccinate everybody who wants it without missing some very important people who are at high risk. And so the phases are phase 1A and people who are 65 and older. So the 1A group is including all of your healthcare workers, so the doctors who work in the ICU or who are giving your testing, all those people who are in contact with people a lot who have possibly COVID. And then there are the people who are 65 and older who are at risk for getting it and having a very bad outcome. The graph on the side over here is meant to show you that the ages on the side, so under 5 up to 80 plus, if you look, there's almost nothing in that young group, and all of the fatalities and everybody who's really dying from COVID is in this very older group. And so we don't want to just give it randomly to people in these middle years if we don't have enough doses to cover these people in the older years who really, really need it. So the goal is to reach them first because we don't have enough for everybody. So in the future, as the supply gets better, and hopefully as coordination is now a little bit better, that'll happen, then it'll just be the way we normally vaccinate, which is everybody goes to their doctor, we have some events, and it'll just be whoever comes gets vaccinated, but we're not at that stage. So the allocation, we are already in 1A. Healthcare workers, long-term care residents. We are now moving into in a week or so into people 65 and older, and that's and that also includes people in high-risk sectors, so education, emergency services, food and agriculture, that's grocery workers, people who are in emergency services, all those people we know who have greater contact and have been shown to have higher risk of infection. And then beginning in the middle of March, healthcare providers are going to just use their judgment on who might be highest risk. And that's because we expect that there's going to be a little bit more loosening of the vaccine supply by that point. So how are we doing this in the city? So the guiding principles are we want to fully use the vaccine supply we have and not waste any of it. We don't have enough for everyone, so we don't want to have doses go to waste. We want to be sure that it's equitable, meaning that it's not just a free-for-all or just who has power or money, but it's based on some real data about who needs it and who's going to have trouble getting it otherwise. We want rapid vaccine access in communities where they have a lot of COVID already, and including those, making sure we do it in a way that includes those who don't have already access to care. And then strategies, metrics, outcomes, everything has to be transparent. And that means we're trying to post everything we can and do these presentations so people can hear how things are going to be done. So just the way it's being done under the direction of the city is that we have a single distribution strategy that includes high volume vaccination sites. And those are partnered with some of our big healthcare agencies. So UCSF and Kaiser and others will be partnering with us to run those. And then community vaccine access sites. So those are more mobile, small, clinic-based, out in the community, hopefully for people who have transportation or childcare or other issues and need to be able to get it in a more convenient way. Hopefully they'll be able to use those sites. And then pharmacies. Pharmacies are using their contract to vaccinate elders, but they also will be expanding that to be able to do other kinds of vaccines. We're hoping with all those strategies, we'll get to that 10,000 vaccines a day. So what's already happening if you look at the gray bars, those are the high volume sites. So we've got City College, Moscone, SF Market, the FEMA, the federal government has set up the Oakland Coliseum as a regional site for us and everybody else around. All of those sites are completely dependent on whether they have enough vaccine. Moscone had to pause because of vaccine supply. So they all can do quite a lot. We cannot do that without vaccine. So there is a little bit of a wait and see here. All of our major health systems are giving vaccine and trying to do high volume. The health network, which is all the city and county clinics, the hospitals, the SFG, all of these places, those sites are all giving to their own patients and staff. And then we have community clinics like NEMS and Mission Neighborhood. They're all giving to their own clients. Not the same group, but overlapping. And then we have neighborhood sites that are really anybody who doesn't have insurance or doesn't have another way. So one in Mission, one in the Bayview. They're working on the other sites, and a mobile site is in development right now. Safeway, Walgreens, CVS are all also doing vaccinations. So what's difficult about this? There's no unified federal or state system for vaccine delivery. It looks like one is being built now, but it was very hard for quite some time to predict when we would have vaccine. So it sort of, it was hard to plan on having it because it kind of just showed up. That should not be happening anymore. We hope they say they're going to give us now a week or 2 weeks of warning so that we can plan and things can run smoother. It's unclear how much vaccine we're going to get or when. The guidelines are changing, and that's based on data. It's based on how it's going to vaccinate in places and how much supply. So the data we're getting from the state is not necessarily on time or the right quality we want. There are lots of data gaps, so it's hard for us always to tell who's gotten the vaccine. And then counties are moving at different speeds. So some counties are vaccinating a lot and using theirs up. Others don't have as much and haven't gotten it together. We are a region, so people go to the county where they think they can get it. So it's a little hard to be in total control of how much we have and being sure that we get it to our residents. But we are making sure that happens. And then it's just operationally difficult. Scheduling the doses, you have to come back for the second dose. We have to have the supply and cold storage and all of these things. So we cannot just do it everywhere. We cannot just do it anytime. It really has to be within the parameters to make sure it's effective. But despite all that, we are managing to vaccinate people. So that's 121,000 doses in, at least one dose, and 35,000 almost of people who have been vaccinated. I think this was of today. So that's about 16% of the population who's eligible, we think. And that's who've gotten at least one, and 5%. So remember I said we were trying to get up to 9. So we're a little over halfway there. So that's great. In terms of people in the city who've gotten it, it's far more than that, right? So the second dose, 2 doses have been administered to 46,000 people, because there's a whole lot of nurses, doctors, and other people who work here, who are at risk here, but who do not live here and don't get counted under our numbers. So how do you find out what you can do? You can go to the sf.gov get vaccinated site, and that'll tell you where you can get vaccinated. We have moved for the city and county clinic sites, so that's Southeast. All of those sites are now doing it based on zip code. And the zip codes right now at Southeast, Maxine Hall, get the list open. And others are going to be 94134, 94124. I'll give you the whole list at the end. In fact, I'll put it in the Q&A. So if you live in one of those areas, rather than trying to get people to go somewhere else, we're trying to get in their area. You can go if you're in one of those high risk categories. So you're a health worker or you're in the proper age groups. That is all. There are lots of sites for questions. Please do look at the formal sites. The government sites have been trying to give as accurate information as possible. So I would go there first, and then I'll answer questions in the Q&A also. Thank you.
Great. Thank you. Can we just kind of virtually give a little love and energy to our amazing panelists, Dr. John and Dr. Bennett. Thank you all so much. The chat has been lit up. The questions have been lit up. You all have already answered 20. There's a couple things that I think that I wanted to hit on for sure. And I gave this feedback when I got vaccinated, that a lot of folks think that you might be immune to passing it along to someone else once you're vaccinated. But can you speak to that? And then also, I know we have, I'm going to just say another couple things here. What is Bill Gates' involvement with the vaccine development due to the rumors that it will inject a microchip? Do you know anything about that? There's legitimate distrust of the healthcare system, which Dr. Bennett, you spoke to. Any plans to not blatantly dismiss blatant facts and address the harm and results related to the harm, which I think you did, Dr. Bennett, but I really do think that the healthcare system as a whole, as you said, has to prove it. And how do we do that? If you all have any ideas on that. And then I'm gonna say, let's see, one more. There's one around when it's open to children. Is there any data that tells how it affects those with severe eczema, et cetera? There's a bunch more in there for that child. So Malcolm, I see you raising your hand. Yeah, no, you want to just jump in? And I
just wanted to say I didn't avoid those two, the questions about Bill Gates and stuff. I thought it was worth discussing publicly. So, Bill Gates, as you know, the Gates Foundation is very involved in promoting vaccinations, et cetera. They're not directly involved in the production of this vaccine. And I hope I made that clear. The history of mRNA research since the 1990s and the development of these platforms since 2003, and safety information in cancer patients and heart disease patients in 2017, 2018. And they were getting ready to launch a study, a phase 3 study in a different virus when along came COVID. The difference with COVID is you got a lot of money and you got a lot of people you could study. It's a global pandemic, which are the main reasons why vaccine studies take a long time. Funding and access to people at risk and access to people who get the disease. So this this belief that every vaccine has to take 5 years or more to develop is the whole point, is to get that out the door. That's old school. We can't live like that anymore. This pandemic shows you cannot continue to have vaccine developments like that. So that's number one. Number two, about the chip. Obviously, Bill Gates, I mentioned, is not involved directly in these things, but I always like to use this example. Can you see me? I don't know if you guys can see me, but
Yeah, we can see you.
you see what I'm holding in my hand? This is a smart.
Yes, your phone.
How many of us has a phone, and how many of us can live without a phone? Your phone has a real chip inside. You can open it up, you can look at it. And let me tell you, it's not funny because it has your name, it pings where you are. We track down criminals, even with your phone off, it's pinging your location. It can predict who you're talking to, when you'll talk to them. You have all this information in here, all the nasty photos you took, all the stuff that you've been searching on the internet that shows up on your Facebook feed. They don't need an anonymous chip in your blood. We have willingly given name identified, named matched information on these chips, and we cannot live without them. So, you know, you can believe what you want, but you've been chipped. We've all been chipped. Unless you're unplugged, you've been chipped. And then the other thing, I do want to respect the question about, and I think Ayana did a wonderful job talking about the history. But one thing people don't know is that when the Spanish flu pandemic came out, a couple of things. Initially, Black community was protected from the severe wave in the fall because segregation was so bad that we actually had our own social circles. And in fact, healthcare was so bad for Black people, we probably got a milder infection earlier in the year that protected us from the bad infection in the fall. But when Black people did get the Spanish flu, they did worse. Why? We know why. Racism in medicine is not new. They were shunted to the basements. They weren't given good care. But the community responded. NAACP, in particular, Black nurses, took care of our community until the war came and all the nurses had to be pulled up to places that they were not allowed to get jobs in before. But we took care of ourselves. And so for me, the answer to that question is, of course, racism, as Ayana pointed out, is part of the history of, in medicine, is part of our history, okay? And so she gave you tools to kind of figure out how to navigate the balance between that history and the need to protect ourselves and our community. A lot of the successes in this country has come on and off the backs of Black people, Black and brown people. We deserve to be at the front of the line should we choose to do so. And we should make that decision from a position of strength and power and knowledge and not fear and not rumors. And so I just really want to value that comment and say, you know, that's why we are here. That's why Ayana and I and Dr. Mo and Tae-Sing and all of you are here. It's been a long day for all of us, but it is important that we take care of ourselves like the community did in the Spanish flu epidemic.
Malcolm, I know Dr. Bennett wants to jump in.
I just have to
Dr. Bennett, can you answer this one too? This question I want to ask too, that people keep asking me multiple times. Does it get into your DNA? Does the vaccine get in or change your DNA?
So great question, and I'll refer back to Ayana for her other point. But for this question, remember, number one, they don't. So these are mRNA. They are not DNA. They cannot get into your DNA. They don't go into the nucleus. So that's number one. Even the DNA vaccines don't, but these two in particular, there's no DNA involved. So it cannot, zero.
Thank you. Dr. Bennett?
I just want to highlight that there are at least now a handful of stories of rich white people doing crazy stuff to get in front of the line, dressing up as if they were from a Native American village in Canada, getting a private plane to get in line and pretend they should have been in that line, pretending to be a school teacher, even though they're a rich something or else. So people are trying to get your dose. If you don't want your dose, there is somebody who will take your dose tomorrow. And this is one of the few times when all of our fighting to be in the right place in line has actually resulted in a place in line. And so if you have a chance, someone would take that from you if they could. So you can have your nervousness and decide not to do it, but just realize that feeling is not shared by many, many, many people, and they will take it. And it is the exact same vaccine across town. So we are trying very hard to keep them out of the line with you and serve your place. People snuck into the city and county line. We had to cancel 400 people by phone. No, you can't come, to keep your place in line. And we would have gotten a lot more love from very rich, well-off people in the city had we not done that. But it got done because otherwise they would suck up all the vaccine that's meant for you. So your place has been saved. You can skip it, but we are fighting to give it to you. So it is there for you to take when you have time and you decide you want to.
Thank you. Thank you, Dr. Bennett. There's a couple questions I'm going to just ask them. So based on the current vaccination rate, when will things go back to normal? Do I have to wait until March? I'm 61 with a compromised immune system. Is there data on Black people globally? For educators, what are your thoughts about teachers and students returning to a school campus? So Dr. Bennett, I'll start with you if you have any of those.
I just answered the one about the compromised immune system. The criteria are changing. The criteria are based on vaccine supply. So as vaccine supply gets better, as there's more coordination and the government's purchasing more sensibly and distributing and things got smarter and better, the criteria will loosen up and they'll loosen up more quickly, but I can't predict. So it's not based on whether or not somebody wants to give it to you or any kind of timing. It's just based on whether we have a dose. So that should get better. I don't see the one about schools, but having had yet another day of trying to force my child to do some homework, I would love for the schools to open. We have lots of data locally, globally, nationally, showing that transmission within schools is extremely low. It is, for the most part, between teachers. When it does happen, it is very rarely child to teacher, sometimes teacher to student, but even that has been incredibly rare based in compared to what it is in an office building or any other circumstance that those parents are in. So kids are getting it from their parents and their family, not from their classmates and schools. And so being in school may in fact be a good place for kids to spend their day, just like it is for lots of other things we try to protect them from. So yes, there is good evidence that kids can go back to school. There doesn't seem to be a huge risk of increased risk to teachers, and they are on the next vaccine list anyway. So we'll see. Everybody wants them open. Some people don't. So we will see what happens, but there is good evidence by this point that the risk is not enormous.
Thank you so much. I know that we have just 2 minutes left, and I wanted to say two things and then turn it over to Director Parker. I wanted to just say, number one, thank you all so much for not enjoying, I enjoyed it. I don't know if you enjoyed it, but for coming to this conversation. Keep having the conversation. We have recorded it. We're going to turn sort of the chat and the Q&A into a fact sheet. Also, if you're interested in having a speaker bureau come to your nonprofit or your school or wherever, there is a speakers bureau that I'm hoping Malcolm can put in the chat about. There is a Spanish speaking one. I believe there's also Vietnamese, Mandarin, Cantonese. So that will all be available. The recording will be available, I believe, on the, and Just Sing will answer that, where the recording will be available. So we'll try to get you all this information. And if you have questions, keep asking them and keep holding us accountable, because I think that, I trust that the medical institutions, have done us dirty in the past. And so we feel this way. We need to keep having the conversations about this and everything else. And we need to hold the systems accountable. And Dr. John and Dr. Bennett have done an incredible job with giving us all this information. And so sometimes it takes a while to absorb everything, because I know we're trying to talk very fast, but I will pass it over to Director Parker. Also, Come see us at the testing sites and at the hub with the new hub that just opened today, 1800 Oakdale. Bayview Y will be there, Rafiki will be there, YCD will be there, 5 Keys. And then also at the testing sites, YCD, DPH, and Bayview Y will also be at the testing sites in Bayview. So we just want to thank Mega Black and thank Director Davis and thank everyone that has really supported us with pushing this all out. So Director Parker.
Thank you so much. So again, just want to extend my gratitude to each and every one of you who decided to take time out of your day to join us for this very important conversation and to get your questions answered. Dr. Bennett and Dr. John, thank you so much for your time. We really appreciate your presence, your work in the community, and being here with us so that we can have a space where we feel comfortable to ask questions, to see reflections of ourselves. In this webinar, we really do appreciate it, and just understand myself and Dr. Monique cannot do this work without you all. So thank you so very much. And to the community out there, thank you again. Keep your head up, stay safe, get tested. And if you so desire, feel free to get vaccinated as we've learned on today. Great information that was shared. We're hoping that what was shared on today answered and calmed any angst that you may have had and answered any questions you may have had. As Dr. Mo mentioned, this was recorded, and so we will be sharing this webinar out. This will be on our social media pages, so definitely go to Rafiki Wellness, Bayview YMCA, you'll find it there, YMCA of San Francisco. And we will do a follow-up with each of you who registered to ensure that you get this information as well, okay? Any final words, Dr. Bennett, Dr. John, Dr. Monique? I'm going to have to get a doctor in front of my name in a minute.
Yes, absolutely. So I just think I came into this, my commitment, because I was quite more involved in COVID a while ago, was that we are a community who needs our elders. We live for them, we grow from them, we have been dependent on them for generation after generation. Everybody needs to keep their grandma. That is what this is about. So don't just make flash decisions. Think about it and take it seriously. I want every grandma and grandpa in our community. They don't always stay with us, and we need to keep them.
Thank you, Dr. Bennett. Indeed, every time an elder falls, a whole forest falls.
Yeah.
Leave it to you to bring my tears on at the end.
And
Thank you. This is why we're here, right? This is why we're here. Dr. John?
No, I just wanted to also echo what Ayana said, and thank you all for this information, and thank everyone for coming and their great questions. It shows people care about themselves, their community. And, you know, I remember something Ayana said at a previous talk I heard from her, that many people asked for a miracle when this happened, and God gave us two, at least two. And so whenever we're ready, it's there. We're fortunate to have a choice. And the main thing is that it's our choice, and we just need to make it when we feel ready. And we hope that we can help you get there if that's your destiny. So thank you so much.
Thank you so much,
We love
everyone.
and miss you. We want to give you hugs.
Yeah.
So when you're ready, get the vaccine so
I
we can hug
know.
you.
Virtual hugs. Virtual hugs.
Director Parker?
Good night, everybody.
That's it.